evening, viewers, and welcome again to your show Neurodigest here on Science TV with me, Sylvia Moramuchabo, your host, and our interpreter Maureen, who actually it is her birthday. So happy birthday, Maureen!
Thank you.
And today we have a special guest. As you can see, today we are ladies full house, and it is August. August is Women's Month, so we will be celebrating with our first show. We are hosting Dr. Susan Wamadi. I was trying to say it in Kikuyu, I've given up in my head. So Dr. welcome. And today we will be discussing neurodevelopmental challenges and behavioral challenges and how rehabilitation and habilitation is done, courtesy of Dr. So Dr. has just come back, so we are the first to host her, so yay! But anyway, that's just me and my excitement. Let's hear from Dr. She will tell us about herself in detail, and then we'll dive into the educational part. Karibuni, don't forget sending your questions on 2058. I'll repeat that, 20508. So send in your questions. Also join us on social media, and you can pass in your questions over there, and we will be sure to engage Dr. and give feedback right back to you. So welcome, Dr.
Thank you very much, Sylvia, for having me here. It's a pleasure to be your first lady, so to come to your show. I'm happy about that. So as you introduced me, my name is Susan Wamipi. I'm a developmental pediatrician, and I have just come back from Canada, where I trained in developmental pediatrics at the Holland Bloorview Kids Rehabilitation Hospital.
Wow.
And it was great being there. I learned a lot.
You learned a lot.
Yes, I did.
So you started from here, then you went there, or you've done all your studies out in Canada?
So it's been a journey. So I started my undergrad in Alabama in the States.
Okay.
And then I went to St. George's University School of Medicine in Grenada, and then we do some rotations in England. Then I came back to Kenya to do my master's in medicine in pediatrics and child health.
Okay.
And then the opportunity to go studying Toronto came, and which I took, and thank God for that.
Power to the women, go get her right there. But like they say, when the tenzi naomo marejoni nyumbani. So you've heard she's been to the US, she's been to the UK, she's been out in Canada, and she's back home. So we're sitting with a lot of wealth of experience from every side of the world. So for your questions, please, opportunities come once, just like current, it passes only once. So be sure to send in your questions. So Dr.
Yes.
Please elaborate to us. So you are a pediatric neurologist, in summary.
No, it's a bit different. I'm a developmental pediatrician. So what
Okay.
we do in terms of our training is we're learning about how to support children of all abilities, and that's mostly childhood disability. And what it entails that you're training, you do some rotations in neurology, you do some in psychiatry, others in genetics, and neuromotor. So there are different aspects. It's just about how to support a child's development who's struggling. So we do a bit of what the neurologists are doing, what the psychiatrists are doing, but it's more of supporting children who have disabilities.
So we can say you're like a two-in-one.
Well,
I'm trying to add power to you.
yeah,
Power to
so
you.
it's more because disability is chronic,
Okay.
and it changes with development. So what's happening for a child who is, let's say, a 3-year-old is going to be different from an adolescent, because it's a trajectory. So the needs change, because you'll find that if a child, for example, is struggling with their fine motor skills, with therapy, you'll see that the fine motor skills improve with time. So it's just about being cognizant of the changes that happen in development at different stages. And the adolescent, of course, is a special age for all children, whether you're typical or atypical. And so it's about supporting those changes in development as they go through this journey. So it's a lifelong kind of support. So we do the pediatric, but then the physiatrists do.
Oh, okay. So for what you studied, you handle just the children,
Yeah.
the childhood of your patient.
Yes.
And then now you hand them over to a different doctor.
We handed them to a different doctor.
But now you work with them for roughly how long? How long does a child come to see you for before you can actually hand them over? Is it something age related or is it milestone related?
So it's actually sometimes it's even institutional, because like where I trained, we saw the children until they were 18, and every hospital has its own age whether you're 14 and above is when we hand you over to adult medicine, but where I trained we saw them until they were 18, and the importance of that was that we had to start preparing them for life skills, because we have to think about what do you want to be when they grow up. They tell us what they want to do with themselves. We teach them skills about how do you apply for a job, what colleges would you go for, and how do we support you through that journey. So by the time we are handing you over to the adults, we've kind of gone through and discussed all those different things with the patient and the caregivers, because of course it's a family-based way that we treat the patients.
So, all right, we had earlier in the earlier shows, we had looked at how what the parents should look out for before they decide to either go for to start early intervention or actually go to see a doctor who can be able to tell them, okay, this is what is the matter with your child, you need to see A, B, C, D. So could you tell us at what point, because now you said you're not a pediatric neurologist, which I had assumed, because there is the developmental challenges, right? And when we're talking about like autism, which is what our season is handling right now, so after I go see, like I go get assessed, all right? So do I start first after assessment and I'm told, okay, your child is autistic. So who will be the first person and at what point do you come in as a consultant for this child?
So ideally, where the way it's set up is that most of the times when you're coming in for your immunizations, when you go to the well child visit, the nurse or the pediatrician do a developmental check. So you'll find that you're asked, like now at 6 months, what is your child doing? And in terms of, have they started babbling? Are they responding to you, interacting with them? When are their first words? So usually, by the time if you go to a good setting, most of the times it's the nurses who alert the parents that, oh, we think that there's a bit of a delay here, and then in a center that's where we try and educate all the health professionals, is that they'll be like, oh, there's a delay in the speech, there's a delay, and we have to be very observant. Like, what are we seeing the child doing? Are they interacting well with the mom? Is there a speech issue? And then from there we trigger for them to be reviewed by a pediatrician. And so where I change, the pediatricians have what's called a beta test, which is like, because it's the MCHAT where they screen for autism, but there's a new test that's a rapid. Like in 10 minutes you have certain tools that you use to see whether to screen for autism. Because the issue before was that how long will it take me to fill out all these forms, but now through people are being trained, at least in Canada, on how to do the RETA test. And it's fun stuff because it's a play-based kind of thing, where you're presenting like an image of, let's say, a baby's picture in a train track, and then seeing what the child is preferring, and then that way it alerts a pediatrician. And within those 10 minutes, I think it's a child who needs to be seen.
But okay, I'm trying to look at that 10 minutes. I remember I had to leave my children for 2 days. Like, come drop the child for 2 days for the process to be done. So are we saying we're behind?
No, it's because things are advancing, because people are doing research. They're trying, because we know that early intervention gives us good outcomes. So people are finding like, how can we catch these children early? And so that, so it's a new test that it's a screener. It's not, so you can screen for something and then go to the developmental pediatrician to get a confirmation. And the important about the screener is, because most people have busy offices, because they were trying, I think the researchers were trying to find ways to make sure that the child is screened for autism. So it's a way of making sure that no one is left out, because you're like in the West, you have, let's say, 20 minutes with your patient. So can you spend those 10 minutes trying to screen, especially when the mom says there's a delay in the language, I'm not sure about the eye contact, the social interaction is worrying me, and you can screen them until 36 months. The screen is just for children who are between 0 to 36 months of age, and it's been designed just to catch children early.
How early? We're talking 3 years, 2 years?
No, we are hoping that we can catch you by the time you're, because most of the times the communication, the social communication difficulties are seen at 3 years of age, and sometimes, and so every child is different, and that's why we're calling it the spectrum. And so it's about the ones when you have an astute physician, they're able to be like, there's something with eye contact, and most of the times moms kind of raise it because you see it's different from another sibling or from the cousins, and they'll raise it up, and it's for us to take that. Sometimes they see it as a by the way when they leave in the office to make sure, no, come back, let's talk about this. Because we worry as parents, and sometimes you're not being able to communicate what you're really worried about.
But you see, then there is this thing that I've been hearing a lot with parents, that the first time they mention some of these issues that you're talking about, the delays, but the doctors don't take them seriously. So is that something that's global now that you've had your practice around, or is it just an African thing? Because my personal story, I always say, like, the time I was seeing the gastroenterologist, when I complained that I'm seeing certain behaviors, it was prescribed like, oh, it's a habit, it's going to end. So you see, that's an assumption, because they would have paid attention to that, because you were having like high reflux, these other signs that we usually get when a child is showing tendencies of being autistic. So is it an African thing that we ignore some of the telltale signs of parents, or we just rubbish it like, no, you don't know, I'm the doctor, I'm the one who knows, and let's not take it seriously, stuff like that. So what's your take on that?
I wouldn't say the doctor is rubbishing it. I think sometimes people are not sure of what they're seeing, and as people are get more awareness, because sometimes things come through research that people are being more aware that we have these children in our communities, because sometimes in the past people would think it's a social construct, it's only happening in the West, but as more people are getting educated, more even in the health profession, you'll find that they're taking it more seriously and trying to find ways to help their patients. It's unfortunate for those who've gone through that journey, but part of my job as a developmental pediatrician is education. So we educate not only society, you educate your colleagues, you educate, because you come with all this knowledge and you want to disseminate the knowledge to help the families who are even in the rural areas. Yes, not just in Nairobi. So the goal is to find ways to catch these children early.
So the trick is in getting it early, identifying it early, and starting to do something about it early. Now, from the vast experience from the different parts of the world that you have been to, okay, well, I'll lean in a bit on the studying part of it, because we've been trying to understand, because one of our guests had mentioned that actually you can catch symptoms of autism when a lady is pregnant, which is something we're like, okay, so how come? And they're like, that's something that can be done in Kenya. So why is it that we are not able to do it? Because we look at the ratio at which we get intervention, or actually just when someone says, okay, something is the matter, we're catching it very late, like 5 years plus. If you're lucky, maybe earlier.
Well, I haven't heard about catching it when someone is pregnant. However, they are, for example, they are associated syndromes that you can get children who have autism, for example, like Fragile X syndrome. And once the baby comes out, there are manifestations that we see. But catching antenatally is at least where I trained. We weren't informed about that. And so it's more as the child is developing is when we catch them, and the pediatricians there are good with referring. Once they
see something is the matter. So would you say that the person, or now that you spoke about education, who's the better person to be able to be empowered in terms of identifying? Should it be the nurse or the pediatrician, or should we focus in a way that we have all of them just be aware? Because sometimes like maybe I'm on in for a flu jab or something like that, and then I realize, oh, by the way, doctor, I have noticed this and this and this. Or should it be at the point when you come and then we're taking the weight, the height, Is that the point at which they should be able to be like, okay, is he talking? Is he, because you can catch it. Because most, nurses are usually very friendly at that time. Like, oh baby, how are you? Give me your tongue. When you're having that interaction. So should that who's the more crucial person that we can actually empower more now that we're on the path of education?
So for me, I'm a bit biased. I believe the parent is the person we should be educating.
Okay.
Because the person who knows the child best is the one who's with the child 24 hours.
That's right. And
so for me, my goal is to educate families who, especially for those who've had a child who has autism or there's some the risk factors within the family, how to educate those parents to say there's something going on with my child, and even if you meet a clinician who disagrees, there's always a second opinion. So I feel like for me, my aim is to empower the caregiver, and then as well as the nurses and the pediatricians. So for me, my target is always the families, because they're the ones. Most mothers are very observant of their children. If they think something is wrong, I think something is wrong.
Yes, that's true. That's true. And actually, I concur with you, because that's the very first person who. But then now the only challenge where that comes is when I am a first-time mother. I don't know what milestones unless I've gone out of my way to actually read about it. So that's the point at which now we hand it over to now our doctors. So that means all of us actually need to be able to learn and at least take caution when we see something is just not quite it.
Right.
Now the one question that I've been dying to ask, is now when you're saying developmental, there was developmental?
Yes.
There was behavioral, right? Do they go hand in hand, or it's either or?
So it's the same brain, so I say they go hand in hand.
Okay.
Because development has different domains.
Okay.
So there's the gross motor domain, which is like, are you walking? Are you able to climb stairs? Can you go down the stairs? And then there's a fine motor, which is use of your hands and being able to help, like self-help skills. Can you dress? Can you use your spoon to eat? And then there's the social domain, and that's where we interact with each other, and that's where like social and communication. So it's social communication domain. And then there's the adaptive skills. Like, are you able to like cognitive, like the way like your cognition with like your intellect? Are you able to know that I can use this spoon to do this? So there are cognitive issues. So development includes different aspects, and behavior comes in with what is the function of that behavior. If a child is behaving a certain way, is it because there is something emotionally that's irritating them? Is it something that's physically that's irritating them, or is it an emotional thing? So that's behavior stems from what else is going on internally in the child. So for us, we deal with both the development and how that development is impacting on the child's behavior.
Okay. So if I hear you right, there's some behaviors that should be like a light bulb. If you see this behavior or if it changes, then it should tell you there's something going on and needs to be looked into. All right. So could you just highlight for us, like what kind of behaviors are we looking at? In terms of behavior, when we say, okay, there is a change, like an example of what kind of change. I'll give you an example. I've been very worried that right now my son changes his clothes every 3 days. No, not 3 days, I mean 3 hours. So like he will just come and you see he's undressing and I'm like, dude, you're supposed to be dressed. But when he decides, I don't want clothes, I don't want clothes. And then it can be very embarrassing. Sometimes you can walk in and you're like, okay, dude, what's up? So you see, that's for me, it would be like, okay, something is, because it wasn't that before. Then we're having this issue of like sleeping pattern. Like you're supposed to be in bed at 9 latest. But then even if I put you to bed, even if I threaten, even if, all the things we try, and he's just not falling asleep, and he'll just be looking at the, and talking to himself. So when we're talking about behavior, is it that, or is it more than that?
So like in terms of neurodevelopment, children who have, and it's just the way the brain is wired, because it's just a different type of brain and how they perceive the world. Sleep is actually a major issue. And so we have children who have difficulty falling asleep, and then there are those who wake up in the middle of the night. And so at least what we're doing in Toronto is that we evaluate your sleep. Are you having difficulty in sleep because of some medical issue? Meaning, are you having obstructive apnea? Like we do like sleep studies, and from the sleep study we're able to try and figure out what is the cause of the problem with sleep. And we give melatonin, which is a natural hormone, which helps with sleep latency, meaning the first, like when you're going to bed, you take it like half an hour before, and then that helps the child fall asleep. Sometimes they wake up in the middle of the night, and sometimes we give a smaller dose of that time to help them keep them asleep. So children who have developmental issues, problem with sleep goes hand in hand, and then sometimes the medication, for example, if you have ADHD and you're taking your meds at night, you're going to have problems sleeping. So we have to look at, is it a medication factor, is it a patient factor that's causing the disruptive sleep.
So we have to
that's very common, especially with children who have autism. Sleep issues are common.
Okay, you just throw me like dozens of like, I'm not like, okay, what have we changed?
Right.
I'm just analyzing that story of like, okay, what has changed in my house? Why are we having this? Because the melatonin, so it is not, it's just it's natural, right? A natural hormone.
Yes, because we have it in our system.
Okay.
And so we supplement it because we've seen that children who have and we think it's genetic, it's something in the receptors that melatonin interacts with, are they the reason why you're having difficulty with sleep? And so we find that melatonin actually works really well for some of our children, and so we tend to give it to help with sleeping.
But that should be under doctor's prescription.
Yes. I think it's important. I mean, because people, like in Canada, you get it over the counter.
Okay.
They sell it over the counter, but then it's advised that at least your doctor is aware that you're taking it.
And especially if you have other medications, you have to really weigh and know if it's going to work. Okay, we're going to give Dr. a break. That we've given her a lot of work to do. We'll take a break. And remember, we are waiting for your questions on our SMS number, which is 20508. So SMS your questions so that we can ask Dr. Susan here, and then we will be able to get educated and be able to take care of our families better and look after our children better, because that is the essence of why we have Neurodigest, so that we can explain all these difficult things and all these behaviors that do not make sense normally. But then when we have guests who are very knowledgeable from every part of the world, and she has been able to experience different ages and different areas of the spectrum. So we're speaking from a point of knowledge. So we will be with you shortly. Don't go away. We'll be right back. Welcome back, viewers, on Science TV, your show of Neurodigest this season, as we handle autism and all related issues and matters that relate to it. Today we are privileged to have Dr. Susan Wadmati, who's a development pediatrician. And again, we say it is Maureen's birthday, our interpreter. So we shall be celebrating that. We hope we can get some water and just clean her up. But while we were on a break and in the first session, we got a question. So Dr. allow me to start with that so that we can put it aside and go to the next beat. Okay. So we have a parent who has asked, is autism related with Fragile X syndrome?
So yes, there are genetic disorders that are related with autism, spectrum disorder, and Fragile X is one of them. And actually, back in Toronto, it's one of the tests that we ask for once we do a diagnosis of autism spectrum disorder, just to make sure that to know whether the child has Fragile X syndrome or not. So it is related.
So what exactly is Fragile X?
So Fragile X is a genetic disorder, as I've said, and it's actually one of the main causes of intellectual disabilities in boys, and it's associated with autism spectrum disorder. And in terms of once you do the diagnosis, we usually do cognitive tests to see where the child is functioning, and because if they have intellectual disability, there are ways that we support that, as well as support the autism spectrum disorder. Okay. So we treat both. Both of them. Yeah, we intervene for both.
Can it come on its own, the Fragile X issue that is?
It can come on its own without autism, yes it can.
Okay. Yeah. So you have to have autism to have it, or can you have Fragile X just on its own.
You can have Fragile X just on its own,
yeah.
but they are like now Fragile X, tuberous sclerosis. Those are some conditions that are associated with autism. Down syndrome. We see some children who have Down syndrome and have autism, and so but Fragile X we screen for.
Okay.
Yes.
Okay. So at least that's something you can just screen for. Like, how do you check? Is it like do you draw blood?
Yes, so we draw blood,
okay.
and then it's a genetic test.
Oh, it's a genetic test.
Yes.
So when they say genetic or no, or the first thing that we think about it, that means it was passed from one person to another one. Like mommy, daddy, somewhere it is first on.
Yes.
Okay, so I hope that fully answers your question. Then we had a viewer asking for an appointment. Please, we shall put her contacts on our Facebook page. Remember, we are also engaging you on the Facebook page, either my page, Sylvia Moramo Chabo, under this live feed, or you go to Andy Speaks for Special Needs Persons, that's the other handle, or you can join us on Twitter, that is Andy Speaks 4, or on Instagram, Andy Speaks. Those are the social media handles, or even on Science TV. Those are the social media handles of which you can engage with us. So for those who would be having any other questions, kindly send them through, and we shall try and tackle them before the end of the show. Now, I'd like for us to move. We've spoken about development, and we touched a bit on the behavior, right? So when we're talking about development behaviors, what are the ones, the most common that you have seen? And are there any that you've seen in the West that are not here in Africa? Is there any difference that is related when we're looking at the spectrum?
Right.
Any signs and symptoms of what you look out for that is noted to be there in the West and that is not here, or vice versa?
So interestingly, Toronto is very multicultural.
Okay.
So we even got patients who are Ugandan, Ethiopian, Kenyan.
Okay.
So and the diagnosis then choose in terms of
apart from boy girl.
Yes, except for gender, but in terms of ethnicity,
It doesn't.
it doesn't. So I got the opportunity to see people from all over the world who had autism, and so that's how I knew for sure that maybe it's cases that we're missing here, and that's really important to raise awareness so the parents know exactly what's going on with their children.
Okay.
Yes.
Now that we touched on that part
Yes.
of boys and girls,
Right.
if by the power vested in you when they said here we are a degree holder,
Right.
so what would you say and from the research and the studies, like,
Right.
okay, could you just tell us what is the difference,
Right.
and why is it more in boys than girls, and why is it harder to diagnose girls than it is boys?
So most developmental disorders are seen more in boys than in girls, and the research is still out there. Whether is it a hormonal thing, is it testosterone? However, there are girls who have autism. The thing with them is that they don't have as disruptive behaviors, and their social skills are a little more better than the boys are. And that's the reason why we need to catch them early, because a recent study showed that women who have autism are more likely to commit suicide as adolescents than the boys do. And so and that's something that got me worried, because I saw it. I follow Twitter, so it was one of the autism researchers, and I saw that today, and I'm yet to read the article. And for me, I was like, is it because we're not catching them early and addressing the issues? And autism has other, I know most parents say the word comorbidity, so I'll say association with mental things like anxiety, depression, and so it's really important for us to screen our children for, especially the adolescents, for anxiety, screen them for depression, not just to do a follow-up as to are your social communication skills improving, but how are you doing
as a person, like you. But
yes.
then that throws in a complex part of it, because we know a good number of autistics don't speak.
Yes.
And like, if I was to give an example, I always refer to my kids because that's all I know, that's my work, right? My son already has issues or difficulty expressing pain, like in terms of like, I have a headache, I have a stomach, he doesn't know how to communicate that.
Yes.
So how much more complex will it be, like if you hit teenage, your hormones are everywhere, and then I am feeling like my self-esteem issues are hitting me left, right, and center. Because at least now you said you've dealt with the from the ages of as early as 2 all the way to 18.
Yes.
So how do you get to, as a parent, because I get worried because that's coming, it's around the corner in a couple of years, but I worry that I will not be able to have that conversation of like, how was your day? Because even now he can't tell me my day was okay, my day was not fine. So it's one of the things that stresses us as parents or gives us sleepless nights. Like, how do I have this communication?
So what we are doing is that we have what's called a psychopharmacology clinic. Sorry, it's just a big word saying it's a medication clinic for children who have autism.
All right.
And so what we did in our clinic is that what I loved about it, and there is that you work in multidisciplinary teams. So you're here as a developmental pediatrician, you have your behavioral analyst who is seated in the clinic with you. So the parent comes in and says, I've noticed my child is irritable, we are being unable to figure out what it is. And so for me as a developmental pediatrician, I do the medical history and I will examine. So is this child in pain because of constipation? Is there sometimes they injure themselves and they are unable to communicate? And so we do a physical exam to make sure that it's not a physical thing that's causing that irritability. And once we've kind of sorted that out, now that's where the behavioral analyst comes in, because there's a reason for every behavior. And we need to know what is like the terms. So we take a history in terms of the terms of behavior. So what's happening just before the behavior occurs? Because you're trying to figure out what's the environment, what are the triggers. And so as you're doing the triggers, you're checking, is it happening at a certain time each day? Is it that's happening more in the morning than in the evening? Is there an activity that the child is doing before the disruptive behavior occurs? And so we work as a team to analyze that behavior and then ask you, so what do you do as a parent? Are you if he's disruptive, are you also disruptive? Because that cycle becomes a vicious thing. So we're looking at both the behavior of the child and how are you responding to what the child is doing. And so we're trying to figure out what's the function of that behavior. What's your child trying to communicate?
So just to interrupt before I lose the train of thought, because I'm just learning. So when you say if the parent is also being disrupted, are you speaking about the reaction, like when your child gets annoyed and frustrated? We've seen children who get distracted. Either they start banging their head, they start turning everything over. So it's the question of how I react as a parent is what you're referring to.
Yes. Are you screaming at your child because you're and of course it's normal to be emotional if someone is tearing up things or breaking stuff, but then the child can feed off your energy, so to speak. And so we're trying to figure out, what do you do? Do you walk away? Because sometimes it's even easier to walk away. Do you put, if the child is harming themselves, how do you put them into a safe place? And so we're trying to figure out what are the consequences, like what happens when the child is doing this. And then that's where we figure out like where can we intervene. And then if the behavioral things are not working, then we start now trying to figure out, is this anxiety? Because we think about the things that are associated with autism. Is this anxiety? And we have questionnaires that we kind of go through and trying to figure out from the mom and the caregivers, like, have you been seeing this? Have you been behaving a certain way? And then is it whether it's depression? So we have questionnaires that we use to try and narrow down what else can be going on with the child. So and that's why I said it's the teamwork. The family is part of the team, the child is part of the team, and you and I, the doctor and the other part and the parent are part of the team, because we're trying to figure out what is this behavior, what is triggering it, and how can we alleviate this.
Now the tougher question. Okay, at least now we know how the West does it. Because when you look at how children from the West, like the milestones they attain and stuff like that, like you can see progress. Because I've been benchmarking and I'm like, why the hell? Why am I not getting there? So here we never get to have that teamwork that you're talking about. So rather, I have not seen a place where I will sit with the occupational therapist, the speech therapist, the pediatrician, me as a parent, and my child in one sitting. We don't have an institution that actually offers that to us, when that is something that's very key. Because if we're a team working towards making this child better. Everyone needs to know what the other is doing. If we're setting goals, we should all be aware, okay, for our child, this is what it is we're trying to achieve, and we're giving them, because remember, they, like if it's schoolwork, it's their own journey, right? For them to actually understand. So we know, like, okay, this is where we are, this is where we want to be. So for you, as part of the team player, this is what you're supposed to be doing. That's what you're saying, right? And if there are changes, now we all are aware, and then we all like handle it from different areas to be able to make it right. That's it.
That's right.
Good.
And unfortunately, the difference is that like the Canadian system is funded by the government.
Oh, it's government funded.
It's government funded. So we can all be in there because of just the way the setup is. That the OT is dealing with the sensory stuff. Like we're working as a team and collaborating as a team to improve the quality of life for this child. But however, like I never lose hope. Is always it's true. You have to be hopeful that somehow,
one day,
that ideal environment. But even here, we're able to still communicate with your colleagues who are the OT person and see whether we have behavioral therapists and kind of come together, even if it's coming together with like writing notes and reading each other's notes, making phone calls. So there are ways that we can still, even if we're not physically all in the room, but we're all communicating with each other to try and help this family.
So we can say like, okay, I notify my neurologist, okay, I'm going to the OT, I'll drop you in on the phone call, like have a conference call when you're doing it so that they can also listen in. Okay, parents, there you have it. That's one way of actually having the entire team handle the situations. And when you see behaviors that do not make sense, that is one thing. Make sure you check with the entire team. Remember, for those who don't raise autistic children, that is exactly what we have to deal with, because you have to have all these therapists and doctors so that you're able to give the child the best service, so that every aspect in their development of their life is actually served well, so that everyone says this is what we intend to do, this is what we're doing, which I think is one of the things we hope our dear government will be working on for us to be able to get there, because she clearly stated in Canada that is government funded, and that's why they're able to sit in a room and all of them actually work towards the patient at the same time. Now, when I was reading what it is that you do, there was a word that I was looking at. Yes, and it says neuro rehabilitation. So could you just expound on that? Because that's rehabilitation, and when we're looking at our children, just dive into it. Let me not prompt it. I'm sure you know what I'm asking.
Yes, I think I know what you're asking. So the word rehabilitate means that we are teaching skills that someone had before and has lost due to injury, due to infection. For example, if you have a head injury, you can lose certain skills. If you have a stroke, you can lose certain skills. And the rehabilitation team tries to find ways to kind of, even if you don't regain everything, there are adaptive equipment that you can use to help on your day-to-day. For example, is it the walker that you can use? Is it the physio? Like now you go for physio, you strengthen those muscles that have lost their function. So it's about function and quality of life, alleviating pain and things like that. Rehabilitation is where you have never gained the skill. For example, if if you don't have any speech, we set you up with a speech language pathologist who will help you in terms of they can assess the motor aspect of things, and then make an assessment of how many sessions you're going to have, just to help you teach the child to speak.
So it's like a brand new.
It's brand new. It's learning skills that you have never attained.
Yes. There was this one question that had been asked some time back, that there is a parent who was trying to understand. They said the child was developing very well. And at 7, just all of a sudden they started regressing. Like they used to talk, they used to be doing okay in class. Then all of a sudden you just notice, okay, we're going in reverse. Stop talking. To a point now the child is on a wheelchair. So neurologically, how would you explain that? Like what would cause that? And Just let us understand, like.
So they are, and most of these are congenital. They are neuromuscular disorders that.
Oh, neuromuscular.
Yeah, neuromuscular disorders that deteriorate in function. So you'll find the child, as time progresses, that they actually are getting worse and they deteriorate. And so regression is a very important red flag. And so for any child who is regressing in any of the developmental domains, it's extremely important that you seek medical help.
After how long?
I would say as soon as you're seeing some loss of some skill, you have to see a doctor, you have to see a pediatrician.
Okay, could you just mention to us a few of the skills that we should be keen on watching out for?
Like for example, one of the what we call differential diagnosis, meaning that like you can have, we suspect you have autism. However, when you have regression and you're a girl, we worry about something called Rett syndrome.
Rett syndrome.
Yeah, Rett syndrome. I'm sure you.
Yeah, I've heard about it. I'm just like, okay, autism comes with a lot.
Yes, and so that one comes in with some regression, and there are tests that we screen, like the tests that we do that can identify whether it's strengths or not. And so what I'd recommend for families is that if you find that your child has lost any skill, they used to walk, they've stopped walking, they used to talk, they've stopped talking, that's a red flag immediately that you seek medical attention, just so that we can investigate and know what it is that's going on with your child.
Okay. Then there is this other aspect when we're talking about the neuro side of our body, right?
Yes.
I know I've always been telling my viewers that it is the communication between the head through your spine to your nervous system, or when we're talking about fine motor skills and such, yeah? Is that correct or not correct?
Yeah, it's correct.
That is correct.
Yes.
Okay. When we're talking about our children not having speech,
Right.
how do we explain that?
So they are, I know they've done like some MRI studies and trying to investigate what is it. Is it because of the way you perceive the speech that you're being, like you find children with autism have poor comprehension or the receptive aspect of speech. And so but then gradually with support and intervention that children learn. And there are those who don't. And so, it's tougher for those families where the child just doesn't attain speech, and we have what's called augmentative communication devices. And thank God for technology, some of these things are downloadable on iPad. We have kids like who we used to see who use the iPad to communicate their needs, and there are services that are predominantly for that. They can start with signing, and from signing they can use the communication devices. And it's really important that parents are open to using those communication devices, as speech may or may not come depending on, and sometimes it's syndromes that are associated with that, so that your child is able to learn early how to communicate what's going on with them. Yes. Okay. So using those augmentative devices.
Okay, apart from the devices now, when you're looking at the general development, what is the most common now? You've mentioned that you've dealt with kids from 2 to around 18.
Yes.
What would you say is the toughest moment for a person living with autism when it comes to development? Because now if you've interacted with them over time, I'm sure you'd know, like you'd be able to identify with some of the cases that you've actually dealt with.
I think the tougher cases are with the adolescents. I feel like that's the age where, like for every adolescent there's the peer pressure. You want to be liked, you want to have friends, you want to be invited over for parties. And so children with autism have the desire to make friends. However, sometimes maybe their approach is not appropriate for their peers, like the way they are interacting with them, like that back and forth conversation. Sometimes they are restricted repetitive interests. For example, we had a child who was into coins, and all he talked about were the coins, and so you find that their peers are not as patient and with that. So for me, I felt when I was seeing them that was a tough age, because they want to be accepted, they want to have friends, and I thought adolescent was a bit tough.
It freaks me out. I will not even lie to you. Every time I think about adolescence is around the corner, and I'm like, okay, is there any magic potion we can take for speech to come?
So, unfortunately, no magic potion that I know of. But you can find a few friends who are supportive. We don't all have to be popular, because then we all went to high school. Not everyone is a popular kid. But having those friendships where they have like a common interest, you do things together, they have the sleepovers. Like as parents, if you're in a support group, I'd encourage those friendships where kids have something in common, and so they're not relying on like trying to find friends for themselves. Like you can do.
It's really hard enough.
I know. So I don't like the term playdates as adolescents, but
they want to fit in so hard, and then community is not like it's like if you're standing around in a circle and you're like shoulder to shoulder. They're trying to penetrate to get into the circle of friends, but then they don't know how to say like, okay, may I join in?
Yes.
Yeah, because they don't have maybe the language or the skill to comprehend exactly how to do it.
Yes.
So now, when as you're dealing with this, we had a case of a parent committing suicide in the recent past. Now, as a doctor, what advice would you give to our parents when we're raising autistic children? Because today, in one of our support groups, there's a parent who's like tired. She's just tired, and we understand it is tiring. There are days I want to scream, I can't scream. Like you said, behavior when they're there. There are days we have a meltdown and I can't handle it. I'm not in the brain space to deal. Because you see, we have the general life is still there. I still have to go to work. I still have to deal with the staff. I have to deal with life's challenges all around. Then I come back and my child doesn't care what happened out there. This is me, this is what I want. And they have their own frustration. So as parents, we do get drained. We do get really, really bogged down. I can tell you for me, it's not been an easy week, not because everything is just difficult. But then, what is about, or at least personally, I have found my way out. Like I have learned I can feel, okay, I'm near end. I need to break and do something. What would you advise for the parents who feel like I can't deal? And remember, we are all our kids have.
Yes.
They already have had their lives trying to balance life with other people, even societal acceptance, which is one of the hardest things that we're still working on. So for us parents, what would you tell us how do we deal with that?
So what I think is to involve like even if it's your extended family or your friends. It's important for families to have a break, and we advocate for your friends, your siblings. Just give 3 hours. Let mom go to the spa. Let her have that time where it is her me time. And what I think is a strength for us in Kenya is that we have aunties, uncles, cousins. We have that sense of community. In Toronto, we arrange respite services, meaning that we hire somebody to come to your home so they can take care of the child so that you can go to the movies, for example, or go for dinner. And since we're here, I feel like it's important to involve in its education of the families that it's good to give your friend a break. It's good to choose a place where that's quiet, that you can go with your child and with the other children. Like to sensitize your friends that let me give Sylvia a break today. Sylvia, you go out, have fun, I'm going to watch your child.
And not feel guilty.
Yes, and don't feel guilty. And we have that sense of community. It's ask for help. Do not feel that you're superwoman. Please ask for help. Ask for a break. Most relatives will be willing. Just okay. Those are my hopes and my aspirations. Is that if I say I do just like a little break to go do my hair. I think for caregivers, that break, even if it's for those 2 hours, it makes a big difference for your mental state of mind, your ability to take care of your child better. I think we have to kind of take responsibility of supporting our caregivers. That's a very big thing for me. Because I'm like, if a mom who is refreshed is a better supporter. A father who is refreshed is a better support system. And so, watch the child for a little bit. Just ask for help.
Yeah,
And
but you see, the
yeah.
challenge comes in, you'd like to ask for help, but these people need to know, or rather, the people around you need to understand your child.
Yes.
Because most of the time, someone will say, okay, I'm ready and willing, then
Yes.
the minute you bring the child, because of some of these developmental behaviors that we are
Yes.
talking about,
Right.
then they go like, what just happened? You know, like,
Right.
I've never seen that in my life, and then
Right.
they can't stand it for a long period of time. So that, I think, speaking from a parent's
Yes,
point of view,
yes.
you analyze this. Even if you have the offers, there is that critical part of, will they handle, like, if a meltdown happens,
Right.
what would they do?
So, like, for me, if you involve your friends in your child's life, you get what I'm saying?
Yeah, yeah.
Have them come over, because every relationship is based on trust and spending time.
Yes, that's right.
And so it's almost like you have to project ahead. The time that you have people come over to your home, interact with your child will kind of get used to them. And that way, that when you need a break, someone really knows and has seen how you've handled the meltdown, how you've handled situations. So have people involved in your home. That way you have some, it doesn't have to be everyone, but people who you know you can trust with your child.
Okay.
It's where those relationships are already formed.
Okay, and siblings?
So the sibling to the
Sibling too, because you know, sometimes
Yes,
I look
yes, yes.
sometimes I look at like the two kids,
Right.
Andrew and Bradley, because they're just back to back. They're like inseparable.
Yes.
Right? They have each other's back, but then they're still at the same time, they can be the worst of enemies,
Right.
and very competitive.
Right.
Yeah. Then we have Daniel,
right.
who is at a different point in life, who's developing differently, wants
Yes.
to be a teenager, because he's
Right.
in that space, he wants to be his own person. But then there are these other younger ones,
Right.
who are also part of the family,
Right.
and there is that sense of sibling responsibility that's
Right.
there. So does that ever get to affect, like, will their development, like for the two who are close to each other, one is ADHD, one is autism. So now we're back to now behaviors and development.
Yeah.
Does it affect that relationship, and even the ones who are matured, do they get affected by the fact that there is a special child in the family?
So they actually do, in the studies that have looked at siblings who
Okay.
grow up, but most of the times they are protective and loving about their siblings.
siblings.
And however, we had a family where the girl wasn't, but like 3 years apart. And what the therapist did is that they have sessions with the both siblings, and they kind of sit down and help them, like, find ways and common ground to play together. And for them, they choose art because we both like art. And so there are ways that the therapist can actually sit down and try and get rid of that sibling rivalry by actually involving them in each other's common interests.
Okay.
So we do target siblings and trying to make sure that those feelings, if they do
If they do come up.
are kind of controlled. So we do siblings.
Okay.
Yeah.
Okay. Sadly, we are time barred. I'm sure we've not even finished everything, but yes, Dr. We are talking to Dr. Susan, who's a development pediatrician.
That's a developmental pediatrician.
Developmental, sounds
you
right.
had it right.
Okay, so we are learning. I've never heard of a developmental pediatrician before. I only know of pediatric neurologist.
Yes.
Hey, jeez. Okay. By the time we're done, I think I'll have a PhD in all of this. But it was lovely having you. Thank you for answering the questions of our viewers. And I'm sure by demand, if we have the questions, we shall reach out to you.
Yes, please.
All the questions you can talk to us on our social media pages, and we shall pass them on to the doctor. And keep your watch on Andy Speaks for Special Needs page, because that's where we have continuous discussions as we discuss what we'll discuss today. What do you feel we left out? Then we can talk to her. We shall have her contact, and I have tagged her on our live Facebook feed. So for any questions and all those who are asking about appointments, yes, we have tagged her on our Facebook post on this show. So you can directly message Dr. She's just gotten back from Toronto with a new whole set of experience. She went to specialize. She's been here to the US and the UK and Toronto. And she's now back home so that we can be able to at least work on our children and help them develop better, and help parents also be understanding. Like she said, the support system really matters when it comes to raising a special needs child. It's not the job of the mother only.
Yes.
It is the job of the entire medical team, plus the parents, plus the siblings, and plus even that nanny who takes care of your child also needs to be involved, because time is what counts. You need to pay attention to every little thing, every small milestone. If anything changes in your child, there are the questions that Dr. has advised that we should actually ask ourselves and make sure that we bring it up to the doctors. So next time we shall be having, today we were supposed to be having an occupational therapist, but we couldn't pass this chance, no way. So we shall be having our occupational therapist next week. So stay tuned and be sure to join us next week on our 9th episode as we continue with our season on autism. And happy birthday once again, Maureen. Yes, it is Maureen's birthday. And we're sorry we're keeping you this late, but yes, we all give sacrifices to make sure that you are informed. Have a good night and see you next week. Bye.
Thank you, Susan.
Awesome.